Hey guys, it's Amanda. I'm going to talk about antibiotic stewardship. First, I want to say that I feel like what I read about the stewardship is something I feel like our pharmacists and infectious disease doctors are doing. I know a lot of the guidelines that it was talking about in the article are things that we do on our unit for patients, but I don't think it's something that nursing has been involved in as much as maybe it should be. Um, I understand the concept. I just think that there's a lot of education that our patients are going to need about antibiotics and overuse because I have a lot of family members and I've taken care of a lot of patients who want antibiotics for everything. And when I try and explain to them it's a virus and the antibiotics can make it worse, they don't quite, I don't know if they really want to listen to that. They really want whatever, they want antibiotics for everything. That's just my personal experience with it, even with my own family. And I would even say probably myself when I was bringing my children up when they were smaller, if they were sick, I wanted it fixed, and everybody thought antibiotics was the fix, and I think that's probably led to a lot of the resistance that we have. So antibiotic stewardship is the right antibiotics at the right time, and it is there's the things that you need to have antibiotic stewardship is to ensure all the orders have dose, duration, and indication. Get cultures before starting antibiotics. Something called an antibiotic timeout, which I'd never heard of before, which is reassessing antibiotics after 42 to 72 hours. Now, I'll say I've never heard of that before or heard it called that before, but I do know that is what our infectious disease doctors do. I also know that when we have a patient who is exhibiting signs of sepsis or any temperature or any signs of infection, we do get blood cultures immediately. I'm not sure if every facility does it the same way, but we do blood cultures times 2, 30 minutes apart. So I do know that we are meeting that guideline, and I also do know that they reassess antibiotic use the 42 to 72, I mean the 48 to 72 hours. The things that it will help with, the stewardship will help with, is to decrease the resistance, which we all know we have a problem with, decrease C. diff, which is deadly. I mean, C. diff, especially in elderly. Actually, my grandmother died a couple years ago, and part of the reason was C. diff. She was that sick from C. diff. She was elderly, and the C. diff she could not handle the infection, and she ended up passing away shortly after she acquired it. So that's a big deal. And then decreasing cost and let's see. Also, some things I was also thinking about when I was thinking about how to get people, or something that we've been talking about in in the media with nursing or with hospital care is reimbursement. I think I've heard that a lot. And I had a physician that was talking to me, I'd say probably about 4 months ago. We've been talking about reimbursement and decreasing reimbursement for a really long time, but he was telling me there have been patient satisfaction scores that have been done for his office, and whenever he denies a mother of a child who's sick antibiotics, his scores go down. They did a research project on their scores, and well, pain medicine of course, but antibiotics, mothers really want those antibiotics. So I really feel like nursing has a large job to do as far as educating patients on proper antibiotic use. Like I said, I do feel like antibiotic stewardship is something we do in my facility. I just we never called it that, and like I said before, nursing has not been as involved in it. It's been more infectious disease doctors and pharmacists that are involved in it. Well, I'm trying to make sure I haven't forgotten anything. So let's see. Oh, the Ebola virus. I don't want to leave that part out. The Ebola virus, from what I'm reading, the vaccines, one of the first initial vaccines, I think, or a while back, they started doing testing in 2003. But recently, the patient who came over from Africa to Atlanta, those physicians were able to um, get a blood sample, and get the actual DNA of that virus and compare it to the virus when it first came out, when it was first discovered, which was 1976. And they were able to actually find, with the processes that they have now, they can actually see where the mutations are occurring, so they can develop better vaccines. I was trying to see, to me, I guess, with the Ebola virus and antibiotic use, Ebola is a virus, so definitely proper diagnosis of the virus, because you don't want to treat a virus with an antibiotic. And I know that people, like I said, people want the antibiotics for certain things, but Ebola being a virus, you wouldn't want to treat a virus with a bacteria, with an antibiotic, excuse me. So anyhow, it looked like there were a lot of different antivirals and things that they were coming out to try and treat Ebola. Some of them, the side effects are as bad as the virus, and almost as deadly as the virus. And the others were not tested in humans yet. There's only a few that have been tested in humans. So I think that's all I've got for now, and thank you.